So thank you, everybody. It's so nice having you all join the call. So my name's Lena, and I'm the Health Promotion Lead for the NHS Bowel Screening Programme. I work across North East London, Newham, City and Hackney, Waltham Forest and Tower Hamlets. I have noticed that there are quite a few people from other trusts as well. And just to let you know that there are health promotion specialists in other boroughs as well. So I'm happy to introduce you to them as well. Okay, I'll begin. Before I begin, I just want to say a lot of the content I'll be sharing today is from the experiences we've had working with communities. And so I'll be going through content that we normally share with people when we're speaking to them, but also I'll go through some of the barriers that we face and some of the techniques we use to overcome them as well. And we'll go a little bit into detail about some of the communities that find it particularly challenging to access bowel screening as well. Okay, so we normally start off talking about bowel cancer first. A lot of people in our communities still don't know anything about bowel cancer, how common it is, and sometimes even where it happens in the body. So this is normally the kind of information we start off with just around the statistics. So a lot of people are quite surprised to find that bowel cancer is the fourth most common cancer in the UK. So very common cancer, and this often quite surprises them. And it's also the second leading cause of cancer deaths in the UK. Now, we come across some communities that are quite frightened to hear these statistics, but more often than not, people appreciate knowing this because sometimes it's a call to action to really take care of their bowel and make sure they participate in the screening program as well. So we tend to just briefly go into the science of bowel cancer as well. So we do show them an image, which is always really helpful, and we just explain a bit of the science around it, and we talk about the clump of cells called polyp, and we explain that bowel cancer is common as people get older. A lot of people have come across the word polyp. Everyone we've spoken to pretty much have heard of this term, but we also make it a point to explain to them that most polyps are benign, so not to worry. A polyp doesn't automatically mean cancer, but it can change into cancer over a number of years. So we just ease people into the conversation around bowel cancer initially. So the next theme we cover are the signs and symptoms. This is often a question people ask, what the signs and symptoms are. So the most common sign of bowel cancer is blood in the stools. We often try and make this topic palatable. A lot of people don't want to talk about stools and poo, so we really try and bring a bit of humour into our conversations with people and just make them feel that bowel cancer is nothing to be frightened of, but it's really important to have conversations about it. So the number one sign we mentioned is blood in the stool or poo. We also go through some of the other signs, which could be abdominal pain, so any cramping or discomfort, and specifically we focus on changes in bowel habits, which often is one of the earliest signs of bowel cancer as well. So we ask people just to notice any changes in their bowel habits. So are they getting diarrhea and then constipated all of a sudden, or are they feeling that they're not emptying completely when they open their bowels? We also ask people to look out for any changes in stool appearance as well. So has the shape changed of the poo, or has it altered in consistency? Something we do mention when we're going through the signs and symptoms is a lot of these signs and symptoms actually mimic IBD, so irritable bowel disease as well. So again, we just constantly reassure people not to be frightened if they do notice some of these signs. But I think the main thing is we ask people to just notice if there are any changes in their bowel habits, because not everybody has the same bowel habits. Some people go to the loo every 2 days, or sometimes even 3 days. So it's just about noticing if anything has changed significantly and just to monitor that. Some other signs could be unexplained weight loss, fatigue, anemia. If there's any bleeding, it could lead to anemia. So just being aware of these as well. With the blood, a lot of people say, oh, it's just my piles bleeding. I'm sure everything's fine. Or people go through the list and they just, I haven't got any of these. But when we talk about screening and the importance of it, we'll understand why we can't just rely on looking out for signs and symptoms. But I think the conversation is very much about just reassuring people not to panic. And if they do notice anything not quite right, they should seek help from the GP or take it seriously, rather than sometimes making their own assumptions, especially where there's blood present. So there are certain risk factors for bowel cancer, and age is one of them. So the risk for bowel cancer increases significantly after the age of 50. However, bowel cancer is sadly one of the fastest growing cancers in people in their 30s as well. So when we're doing health promotion, we're ensuring that people are at least aware of the signs and symptoms. And when I talk about screening, we have reduced the age at which people are automatically invited for screening now. So that's really a step in a positive direction. In terms of sex, so it affects both men and women equally up to the age of 40, but after the age of 40 and 50, it tends to be slightly higher for men. There is a lot of research to show that the element for men is centered around lifestyle as well. But what we are finding anecdotally is that when we're having the conversations, men tend to be less likely to visit the GP if they do have any symptoms. So we're really encouraging men to visit the GP and just take better care of their health, just in terms of diet and lifestyle as well. And just, I guess, become more confident talking about their health if something isn't quite right. So medical or health history is also a factor. So inflammatory bowel disease, like ulcerative colitis or Crohn's disease, especially if it's long-standing, that can also increase people's risk of bowel cancer as well. Again, as I mentioned, some of the symptoms are exactly the same. So again, not to worry and panic, but just make sure the GP is aware of this and that you do especially take any changes more seriously. Type 2 diabetes as well, a lot of research showing may also increase risk. So when we're delivering our workshops, we talk a lot about diet and lifestyle just to support people with type 2 diabetes as well. As with many other cancers, there's a family history element also. So having a first-degree relative, such as a parent, sibling, or child with bowel cancer may increase people's risk as well. So again, we encourage people to ensure that their GP is aware of this. In case they do present with any signs or symptoms, it will be a red flag for the GP just to, I guess, fast track any diagnostic tests that may be needed. With bowel cancer, there are also certain genetic syndromes. So these are things that genetically predispose people to bowel cancer. So something called Lynch syndrome has also been found to increase risk. So it's just about having an awareness of this for people and just being mindful that, yes, they may not have the signs or symptoms, but there are other things that may increase their chance of getting bowel cancer as well. Okay, so there is also a big lifestyle element to increasing someone's chance of getting bowel cancer as well. So diet naturally plays quite a big role. So when we're advising people about dietary factors and I guess making small changes to lifestyle, we encourage them just to maybe reduce their intake of red and processed meats, which has been found to increase risk of bowel cancer, and also a low fiber diet as well. So our conversations focus a lot around gut health and well-being related to diet and nutrition as well. Obesity is also a risk factor, and all of these are actually risk factors for many other types of cancer as well. But we find that it's really important to have these conversations so people realize the importance of lifestyle factors and making changes to reduce their risk as well. So an elevated body mass index increases risk. Physical inactivity, so a sedentary lifestyle, can contribute to risk as well. Smoking, the common culprit, so long-term tobacco use, in addition to alcohol, so heavy or chronic alcohol consumption can also increase people's risk of bowel cancer as well. So I'll talk about early detection and bowel screening now. So I just want to say that this this training session is it's quite a shortened version of the training we normally offer. So if at all anyone, any GP surgeries or any of you would like a more detailed training session, please do let us know. My colleague Mansi, who will be talking about breast screening, they also offer training as well. So we're happy to have more in-depth conversation. So when we talk about bowel screening, I feel this comes in with a lifestyle step that people can take. And what we're encouraging people to do is to realize that sometimes bowel cancer and many other cancers can appear without the signs and symptoms. A lot of people just rely on that. And I've spoken to people who have said, I haven't got any of those. I'm fine. I'm doing fine. I've got a healthy lifestyle. But we just try and emphasize that with a serious cancer like bowel cancer, the symptoms can be hidden. And it's really good to take advantage of the screening program that's available and to encourage people to make it a regular part of their health MOT. So we'll talk a bit about the screening program. So before we talk about screening, a lot of people don't realize why screening matters in the first place. So this is also a conversation we often have to have just to put things into perspective for people. So the simple message is early detection saves lives. So cancer found early is easier to treat. That's the key, one of the key messages we share with everybody. And the fact that it also reduces the risk of late stage cancer. So this is quite an eye-opener for everyone we speak with. So we do make sure we share just the importance of screening. And just in terms of the benefits of screening, just emphasizing that it can detect issues before the symptoms appear. That's the whole point of screening. We're offering it to people just by virtue of being in the risk age group, regardless of whether or not they have symptoms. So sometimes this adds to motivating people to participate as well. So we'll go into the screening program. So up until I think year before last, it was people aged 60 to 74 who were eligible, who were invited for screening. And since then, we've reduced the age at which people can be invited for screening automatically. So the good news now in England is that everybody aged 50 to 74 is automatically invited every 2 years. They do need to be registered with a GP in order to receive the test kit. And it's really important that the GP practice has their correct address as well. So we're really encouraging people to ensure that the GP has their up-to-date information, because if they don't, then they'll miss out on the screening. A lot of people ask, why does screening stop at 74? So we're going in the right direction, and hopefully in future we'll be able to expand the age further. However, people above 74, they can still opt in for bowel screening, which is really good news. They just need to contact the free phone number and ask for one. So they can just wait 2 years and carry on doing it. They just have to opt in. And the purpose of the screening, the FIT test, the screening test, is that it detects tiny amounts of blood in the poo, which can't normally be seen. So we mentioned earlier that one of the key signs of bowel cancer is bleeding from the back passage, but sometimes this bleeding, this blood can be hidden. So, and that's where the screening comes in. It picks up a tiny amounts of blood that we won't be able to see ourselves. We do make sure we tell people that the FIT test at this stage, it doesn't diagnose bowel cancer. It's to assess if a further test in the form of a colonoscopy is required. So it's phase 1, because bleeding can be for other reasons as well. What we find is when we're doing our sessions, sometimes at that stage, gauging from the audience, they might not be ready to hear that they might need to do a colonoscopy. So we really try to understand how receptive people are to hearing about even the bowel screening test kit in the first place. And then we see how much information we want to go into too much depth about. So we ease people into the conversation around bowel screening. But the FIT test is essentially the first phase to decide whether the further test is required. Once people send their kit back, the results are sent within 2 weeks. And the good news is most of the results come back normal. However, cancers are being found as well. And this is something we emphasize, that the bowel screening program is saving lives for people who are in the risk age and don't have any symptoms. So we make sure we emphasize that information to them as well. So this is what the bowel screening test kit looks like. So it comes in the post, and a week or so prior to receiving the test kit, people will receive a letter just priming them, getting them used to the idea of bowel screening, and just informing them that they will be receiving this test kit in the post. So we're not shocking people straight away by sending this kit. So a week later, they'll receive the kit, and it's such a simple kit to complete. Back in the day, it was a lot more complicated. There were 3 poo samples that needed to be sent through. With the fit kit, it's just 1 tiny sample. And what the research has shown is that if we can encourage an individual to do their screening for the first time, they're more likely to do it again because they've gotten over that overall aversion around it, and they just feel a bit more confident doing it again when it arrives in the post. So this is what it looks like. And in the pack, you've got the fit test, just a little bottle. This will be registered to the individual. It will have a unique QR code, which will be scanned when it's sent back, and the individual's results will be recorded, and the GP will also receive a letter indicating if the patient did their screening or not. So although this kit doesn't come from the GP will still be aware if someone's participated in the program. So in terms of completion, it's a really simple step. So people need to write the date on the bottle. So a lot of people forget to put the date on, and then they often have to do the kit again because it will be deemed a spoiled test kit. And in Northeast London, we're finding that a lot of people are forgetting to do this. So this is one of the key things we remind them to do. We're finding that the trickiest thing for people is to collect the poo sample. I mean, as soon as we mention that it's a poo sample, some of the expressions we see in our workshops. So we understand, we accept that it's not the most pleasant thing to do. But again, we put things into perspective for people and help them understand that it's a small poo sample and it could save your life. So that's an essential message that we often share with people as well. The easiest method of collecting the poo, and this is what people have told us, is using layers of toilet paper in the toilet bowl or pooing onto toilet paper as well, and then it can be disposed of, flushed down the loo straight away. The poo shouldn't touch the toilet water, and they just need to open the bottle. There's a small stick as part of the lid, and they just scrape the stick along the poo until the grooves on the end of the stick are covered, and that's literally it. And then they pop the stick back into the bottle, click it shut, and that's the bowel screening test kit done. There is an envelope that's provided. It's just in the second image there, and it's all paid for and stamped. And once they've completed the little sample bottle, they just pop it into the envelope and post it off. It does need to reach the hub within 10 days. So what we are encouraging people to do is to complete it as soon as they get it, really. If they can do it within a couple of days, and if they can keep the test kit in their washroom area so they don't forget to do it, that normally helps people remember to do it as well. One of the biggest things, as I mentioned, is the poo sample collection, but a lot of people are nervous about the amount of poo that's required. So we just remind them that it's just such a tiny sample that's needed, and it's really not that much of a big deal. And we take a demo test kit with them, or we have leaflets, and we just show them that it's really simple to do. And when we are talking to people, there are often people who've already done the screening kit as well, and they share their experience. So it just helps people feel a bit more confident about it. Okay, so in terms of the pathway, so once the individual's completed the kit, they could get a result that's normal, in which case blood wasn't found, so they don't need any further tests, and they'll be invited again in 2 years if they're still in the age cohort. In instances where the results are abnormal, they will need further tests. So this will be a colonoscopy, and it's quite daunting for people, of course, to receive an abnormal result. And we have our specialist screening practitioners to really support the patient through that journey, and they'll discuss the colonoscopy with them. They'll support them in every way, answer any questions, and just to assess fitness of having a colonoscopy as well. So we won't just leave people to it. We will be supporting them throughout that journey, and hopefully, if everything goes well with the appointment with the SSPs, the colonoscopy will then go ahead. Sorry, I think I can hear. It's somebody. Sorry. Okay, I'll carry on. So I want to talk about the barriers to screening participation briefly. So there can be a number of barriers, and we're finding that certain barriers may be more prominent in the following groups. So in the work that we're doing for promotion, we're ensuring that we do a health equity audit to assess which communities, which areas in Northeast London have the lowest participation rates, and then we target our outreach activities accordingly. But we're finding obviously people living in high areas of high deprivation have poorer uptake. Also, people with a learning or physical disability, ethnic minority communities as well, especially South Asian and Black communities, people experiencing homelessness, also individuals with severe mental illness, and LGBTQI plus communities as well. So these groups will always be a priority for us in the interventions we work on. And I'll talk a bit about some of the work we're doing as well, and how we can work together to see if we can do some targeted work to support people. Now, specifically related to bowel screening, there are a number of barriers that come up. So this isn't an exhaustive list, but these are just some of the common barriers that we face when we talk about bowel screening. So generally in our communities, there's just a lack of understanding about bowel cancer and just about why screening is important and relevant. So these are really important conversations we have when we're trying to encourage somebody to participate in screening. There are practical barriers just about the test kit itself. Just accessing services sometimes is a big one for people. Sometimes people miss the test kit, so we emphasize that it's important that we have the correct address for people. Some people just don't have time, and they're just uncomfortable with the poo sample collection. So again, our conversations really center around, I guess, reminding people why screening is important, but how simple it is to do the screening as well. And it comes to your home. You can do it in the privacy of your own home, and it's just really simple to do. Fear about a cancer diagnosis and just talking about cancer in a lot of communities is still a big factor. So we just remind people that the treatments for cancer are so much more advanced now, and it's just really simple to do the screening. And yes, a cancer diagnosis can be anxiety provoking, but screening is there to find it early and to save lives as well, especially with common cancers like bowel cancer. So again, just reminding people that it's really worth doing. We often work with many communities from different ethnic groups as well, and they'll have certain cultural elements or beliefs that may prevent them from doing screening. So we really try and understand what these barriers are, and we try and do have content that's really targeted to addressing some of these barriers as well. And where we can, we just tap into any cultural wisdom that the center coordinators we work with, or anyone we're working with, they have. So we really try and research that to see how we can really encourage people to do screening just based on any religious beliefs they have as well. And of course, another common barrier is just the language barrier. So we try and deliver our sessions in different languages if we can. And we keep the content very simple, just using images, using animated videos. There are so many resources that can be used to really encourage somebody to do screening as well. So with bowel screening, hygiene is a big one. So we just remind patients that they don't actually touch the poo. It's quick, safe, and hygienic to do. We've got resources in many different languages, and we often refer people to the online resources as well in their preferred languages. And again, dealing with the fear of the diagnosis, we just remind people early detection makes treatment much easier as well, and that most people diagnosed at an early stage do survive, and that's the whole point of screening. It is to find it early and detect it early, and just reminding people also that screening can help prevent cancer, and we don't want to wait until the symptoms appear. We want to do the screening before the symptoms appear, just by being in the risk age group, and that's why people are being invited as well. So sometimes where we have limited time to talk to people, simple catchy messages can often do the trick as well. So what I'm finding in my work, to address some of these barriers, is that often with the communities, it's quite important to build a rapport with them first, and just gauging openness to discussing something like screening and using our language skills where possible. And I guess having empathy that there may be other things going on for the individual as well. There might be health issues going on, there might be financial problems, just a myriad other issues, and just being mindful of that. So it's really quite important to see where the person's at in terms of health and their openness to screening. But some of the messages we use that can really make a difference is just something as simple as prevention is better than cure. The test kit could save your life, and it's saving hundreds of lives every year. And just not having symptoms doesn't mean no risk. So these are just some examples, but I'm sure in your work you'll come across other catchy messages that can really help drive home the importance of screening as well. So I am coming towards the end. I don't know how I'm doing for time, Lubna, but
we're coming up
over?
to we're 1:30, so
okay, perfect.
If we want a couple of minutes for questions, we do have some in the chat so that we can
sure.
raise those as well. So
sure. So I'll just quickly go through this. So we do have a health promotion team, and we're really keen to work with any GP surgeries, and we're really open to ideas and being creative, because you know your patients more than anybody. But we have been doing a lot of work locally with GP surgeries. So we've delivered online and in-person sessions for any surgeries that have PPG sessions as well. We do awareness stalls, and we co-deliver sessions with any health coaches and social prescribers as well. I mean, you guys are an amazing resource, so we'd love to work with you, and we'd also love to co-design interventions with you as well, and just do any targeted work for any non-responders to bowel screening. We have got quite low uptake in Northeast London, so we're always open to ideas and tapping into your expertise as well. We've got a load of leaflets and material. So some practices, they display posters. We've got animated videos. So if you've got a screening in your waiting area, there's so many animated videos that you can use with subtitles and in different languages. And as I said, we are very happy to do some awareness stalls and one-to-one sessions, even at coffee mornings. A lot of practices, I know in Hackney, have got coffee mornings going on. So we've actually delivered gut health and well-being sessions. So we're not just talking about bowel cancer and screening, we're actually talking about digestive health. And this is really resonating with a lot of people. So we're offering information and guidance about just looking after gut health in general, but what kind of foods we should be eating just to keep the bowel in good working order as well. And our workshops have received really good feedback, so we'd love to hear from you. So these are links to bowel cancer screening information and resources. Again, this isn't an exhaustive list, but the NHS website's got great resources, the North East London Cancer Alliance website also, and all the materials in different languages are listed there. If you feel anything is missing, just please do get in touch with me, drop me an email, and I'd be more than happy to help you. And that's the free phone number there as well, if you wanted to share with any of your patients. Thank you, everybody. As I said, we do offer more in-depth training sessions as well, if you're interested. I think there were some questions you mentioned, Lubna.
So there's some in the chat. One of the first questions was, would FIT be helpful if frank PR bleeding?
For frank PR, so that would be, so there are two pathways. So the bowel screening pathways where you automatically get the kit if you're in the bowel screening age. However, if there are symptoms, the other pathway is the GP pathway, where a FIT is also offered. The sensitivity rate for detecting blood there's a lower threshold via the GP practice. So that would be, I think, the GP's call to decide if the FIT test was the right test to use to assess that.
I don't know if Dr. Dadaboy is still on the call. He's just interested in doing some targeted work for his PCN. So if you get in touch with him after the call.
Sorry, just responding. I'm actually here because our PCN has actually identified that we have low levels of screening uptake So as part of including smoking cessation, we are trying to work hard to increase uptake of screening, in particularly as part of our health inequity project. So I'm reaching out. I'll put my email in the chat. So outside of this, if we can liaise, I'd be really grateful. Thank you.
Wonderful. Thank you.
Sorry, I just impertinently answering my colleague's question. Anybody who's got frank bleeding should really see their GP. Outside of any screening, don't wait. See your GP. Get assessed. Thank you. Sorry.
Thank you, doctor. Thank you. I think Ruji's got her hand up as well. Hi, Ruji.
Sorry, Lena. I've got it out by mistake. Sorry.
No worries.
Okay, no worries. We've got Nadia asking, could you send us the latest information in different languages? So I think some of, so if you can send that over. Any resources or suggestions for uptake amongst those with unstable accommodation or homeless, please?
It's a very good question. So, so we're working with practices, homeless practices actually, and they receive the test kits for the patients at the practice. Now, I don't know if that's the case with all practices, but we have got wonderful resources that have been designed for the homeless community, so I can share those with you as well if that's helpful. But we can also take this conversation offline and discuss if there's a particular homeless community in an area that we can work with. Any others, Lubna?
There's no more in the chat, but if there's anybody else that wants to ask a question, otherwise we can wrap up and move on to breast screening.
Sure. Thank you, everybody. Please drop me an email. Happy to hear from you. Thank you.
Thank you, Lena. Mansi, if you'd like to move on to breast screening.
Of course. Hi, everybody. My name is Mansi Tara, and I'm the Health Promotion Lead for the North London and Central and East London Breast Screening Service. Are you able to see my screen with the presentation?
Yes, it's clear, Mansi.
Brilliant. So it's hard to follow on from Lena. She does such a great job at explaining phrases and barriers. And I think just to re-emphasize that, they do kind of overlap in terms of, the barriers that you see, or like the key phrases for cancer screening and detection. The earlier you find it, the easier it is to treat. You will probably hear me say those as well. So I'll keep it brief on things that Lena has already touched upon. But I guess the intention today is here to, talk about breast cancer. And I know in some ways you will know a lot about this as well. But this is something that we do when we're talking to the community and talking to the patients as well. So we know that breast cancer is the most common cancer in the UK. 1 in 7 women will be diagnosed with breast cancer in their lifetime in the UK. It is more common for women over the age of 50, but really anyone, so people of any age or gender can get breast cancer. So even men can get it. They just get it in very, very low numbers. In 2022-23, over 16,000 breast cancers were found through breast screening, and this program does save 1,300 lives each year. So it's not all gloom and doom. We can do things to reduce the risk of getting breast cancer, and by 23%. If we maintain a healthy weight, exercise regularly, have a healthier diet, and reduce alcohol intake, all of these would reduce our risk of getting breast cancer. So when we are out and talking to people in the community, we do emphasize that when we say exercise, we're not expecting them to join the gym and start working out for an hour every day. I wish I did that. But it's more about making healthier choices. So, getting off or stop earlier on the bus or the tube and kind of getting that 20 minutes, 30 minutes of walk every day can also make a difference to their health and their lifestyle. And I'm pretty sure you kind of pass on these messages to the patients anyway. And then we talk a little bit about breast awareness. So as I mentioned, people of all ages and gender can get breast cancer. So it's important for everybody to be breast or chest aware. And there isn't a right or a wrong technique to kind of practice breast awareness. It's about getting to know what's normal for you. So, an individual would know their body best. So what's normal for them? A technique that we recommend following is TLC, which is touch, look, check. So we recommend that people touch their chest or breast and look for any kind of changes, any lumps that they can feel. And this should extend up to the clavicle and to the armpit as well, because so collarbone or armpit, because our breast tissue extends to these areas. This could be done in the shower. It could be done, in a safe place for them. They should look into the mirror and look for any changes from normal. And I'll go into some of the common signs and symptoms that we do find associated with breast cancer. And if there is any change from normal, we recommend that they go to their GP without delay. We say that women and men should practice breast or chest awareness once a month around the same time of the month to be consistent. Maybe put in like an alarm on your phone, or the first of the month, payday, whatever works for that individual. So this is one of the images that we use a lot, especially for modest communities when we are out there and talking about breasts, because it's not, that's one of the barriers. People think it's inappropriate, or like it's not something that they openly talk about. So there are kind of ways around sharing those symptoms. So pretending that these lemons are breast or the chest. If there are any thickening of an area, if there's any dimpling, changes to the nipple where there's crusting, or there's any unusual new fluid coming out of it, if the breast is red or hot to touch, or any skin sores, bumps which kind of come out of the skin, if there's a new growing vein that hasn't been, that they haven't seen before, is any sunken nipple, any new change in shape or size to the breast, or a puckering or orange peel appearance, and also hard lumps. So that's something that they will kind of have to feel for while they're practicing breast or chest awareness. So we recommend that if they see any of these changes, then they should go to their GP. As they start practicing monthly breast or chest awareness, it could be something that's not normal for them, which is not mentioned here. So if there's any change from normal, we recommend that they do get seen by a healthcare professional. Moving on to breast screening. So we know that screening saves 1,300 lives each year in the UK. It's essentially an X-ray, which is called a mammogram of the breast. And the results of this are examined by 2 trained healthcare professionals who look for any unusual change. Keeping on to Lena's messaging, the earlier we find cancer, the easier it is to treat. So that is what breast awareness or screening helps us do. So while breast awareness is good for changes that we can see or feel, breast screening would actually help us identify changes that are too small for people to see while practicing breast or chest awareness. This image kind of gives an idea of that difference. So the bottom pink kind of circle is lumps that you might feel for when women are practicing self-examination or breast awareness. The second smaller dot is what a healthcare professional might see while they are giving someone a breast examination. And then as the dots get smaller, those are the changes that we see in our mammograms. So, and because we compare the films to the previous ones, if a woman's coming for their regular mammograms, we can find changes that are very, very small. As compared to what they might find on self-examination. Did anybody have a question? It's all good, all good. And then in terms of eligibility, so if the breast screening service gets the data from GP practices. So all women who are registered with a GP, so all people registered with a GP as female between the age of 50 and 71 will be invited to breast screening every 3 months. People over the age of 71 are still eligible for screening. We just don't send them that invite every 3 years, but they can call us and book their appointment, so self-refer into the program. So people who are eligible for screening would be cisgender women, trans and non-binary people assigned male at birth who have taken feminizing hormones for 5 years or more, and trans men and non-binary people assigned female at birth who have not had top surgery or bilateral mastectomy. And if there is someone who is 53 years of age in your practice and has still not received a breast screening invite, they should contact the Breast Screening Hub, which is the main kind of scheduling service for all of London. Also wanted to share a little bit about how the invite comes in. So the woman would receive an invite via post 2 to 4 weeks before their first appointment. Then they're sent reminder text 7 days and 2 days before that appointment. Now they can either choose to attend this first appointment or miss it, which would be DNA. If they miss it, if they attend, they're recalled in 3 years after their outcome is kind of if the outcome is normal. If not, then they're referred on to further tests. If they miss the appointment, they're issued an open DNA letter 3 days after. And then they're given a second timed appointment. So this is new. They're given a second timed appointment 35 days after their first appointment. Again, they're sent reminder text 7 days and 2 days before, and then they can either choose to attend this appointment or miss. At this point, if they miss their appointment, the service doesn't, as a standard, send them any more kind of nudges to attend. But often we partner with GP practices and PCNs to request them to send that kind of nudge reminder, because we know if it's coming from the GP, it just holds more weight and they're more likely to attend. The woman would be given a breast screening appointment within 30 minutes via public transport from their postcode. So we are not screening via each GP practice, but via where the women live. They can change any aspect of the appointment, whether it's the date or location. And let's say if they work in South London, but they got an appointment in North London, which is where they live, they can actually call us and change the appointment to South London, nearer to their workplace if they kind of want to go in their lunch break. So though we give a timed appointment, they are free to change any aspect of that. They will always be seen by a female mammographer at their first breast screening appointment. That's what a mammogram machine looks like, in case you don't, if you haven't seen one before. What's done is we take 2 X-rays of each breast. One's a top to bottom view and one's the side view to get most of the breast tissue. We ask the women to undress to their waist, and while that's happening, it's only them and the mammographer in the room, nobody else, and the mammographer will always be female. On the day, we recommend they wear like trousers or skirts because it's easier to undress, and then their breast tissue is placed in between those 2 plates, and then the white plate's kind of brought down to flatten it out to hold it in place for an accurate image. Now, most women are okay with the screening appointment. Some find it uncomfortable. Sometimes, rarely people find it painful as well. But they should talk to their mammographer about their kind of the appointment, and the mammographers are there to support them to process. Once the breast screening appointment is over, and the whole process takes about 6 minutes, the results are sent to the woman in the post, to their registered address, and to their GP as well later. Sometimes women are called for further assessments, which is called the screening assessment appointment. So this is kind of an image that helps us understand, for every 100 women, right, 96 women have no signs of cancer and they're recalled every 3 years for their regular breast screening. 4 women might need more tests. And then of these 4, 3 again are found to have no cancer and then are recalled every 3 years. But we do diagnose 1 woman for every 100 that we screen with breast cancer. But then I think the messaging again is that the earlier we've caught it, the easier it is to treat. So, sometimes when we're out there, people talk about not wanting to not finding out that they have cancer, or they're scared of coming. So I think it's reassuring to tell them that 99% of women who come in actually are okay. But that 1 woman that we do find to have cancer, we found it earlier, so they would have better outcomes. So I spoke a little bit about women missing their appointment earlier. So this slide just goes over how an uptake for your practice is calculated. So it's a little time sensitive. From the time that a woman's invited to their appointment, their episodes open. So they need to attend their missed appointment within 6 months to contribute towards your practice uptake. So if you see the figures of uptake in your practice, if women from your practice are missing an appointment, they attend within 6 months, that's when your uptake figures would go up. Though we do recommend encouraging all women who've missed an appointment, even beyond the 6-month period, to attend, because if a woman's attended once, they're more likely to attend again, and then you'll see the benefit of that in 3 years' time when they come back for their regular appointment. Right. And then I wanted to also talk a little bit about how we share reports with you. So we know that historically we were sending you, or even now, we do send you a DNA report in the post. And we acknowledge that it's not the easiest way to code and log onto your system. It is tedious. And unfortunately, our systems don't talk to each other yet. But what we are trying to do now is make that paper into an electronic PDF and send that to you if you do choose to opt in for this service. So if whatever women from your practice would have attended their breast screening appointment or not attended, the reports of that outcome will be sent to your practice with your kind of preferred nhs.net email ID. All you need to do is send an email to the email mentioned on the slide with your GP practice code, name, and the preferred email address that you'd like for us to send this PDF report to. And then I think, there was some conversation in the chat about people experiencing homelessness. We have a few projects that we run for people with learning disabilities, people experiencing homelessness. We also provide additional adjustments for people with physical disabilities. So some of these adjustments are that they can bring a friend and a support worker along with them for the appointment. We can give them a longer appointment slot. For people with learning disabilities, we can share materials in easy read. We also do have materials in lots of different languages. So for the people who put in the chat about different languages, we can come with those resources or even signpost you to online websites that actually send you printed resources free. We also offer pre-visits for vulnerable groups for them to get to know the team, see the center, see the machine, meet the mammographer, and familiarize themselves with the kind of appointment before they actually come for the actual appointment. And then I think this, a lot of this already because you meet your patients every day and you talk to them about lots of sensitive conversations and topics about their health. So I think it's just something that we follow when we are in the community, kind of talking about how do we talk about breast health. Some of these topics can be triggering for people, maybe because they've had a personal experience or they've had someone in their family who had cancer. So it's important that we set a stage and create a safe space for sharing, knowing the basics ourselves. So the presentation that I kind of did right now, very happy to share with everyone. So you have those facts and figures to go to and talk about the importance of screening, but also acknowledging stigmas. So there might be a lot of conscious or unconscious stigmas that come up in the conversation, or there could be cultural barriers. Like I mentioned, sometimes, we go for events and then people would just say, oh, hope there are no inappropriate images in the presentation. So breasts are considered inappropriate, but, I think it's about acknowledging that and then coming from a space of maybe respecting that kind of cultural belief, but then also bringing the importance of screening and kind of talking about how it's a part of their body and it's important to take care of themselves. So I think those are some things that we follow. And in terms of the barriers, I think Lena went over a lot of these already, so I wouldn't spend a lot of time on it. But I think for us, it's really important that the GP has up-to-date kind of phone numbers and addresses for the women, because that's where we get our information from. For people experiencing homelessness, they need to be registered with a GP for us to be able to invite them onto the program. So again, I think we do a lot of outreach with homeless hostels to kind of reiterate that. Then there are stigma and cultural barriers that I mentioned. So I think it's important to talk about how looking after your body is considered important in most cultures. You will always be seen by a female staff in a private room. And then there could be language barriers. We do see that quite a bit. So if people are feeling a little nervous about coming for their appointment because they don't speak English, so you can always reassure them that we have phone translation. So we have language line where there will be a person on the other line translating for them. But we also have iPads in all of our screening sites where just for like the 3-point identification or basic conversation, we do use iPads with Google Translate for the women. Again, I think embarrassment could be one. It's nobody feels comfortable kind of undressing to their waist. So acknowledging that, making them comfortable, letting them know it'll be a female always, and that the mammographer will do everything to make them comfortable. And essentially, it's coming to a healthcare professional. So, we're not here for any judgment. Fear and anxiety is a big one. So, people don't want to find out. We hear something like, why test fate? Why would I go and find out if I have cancer or not? So again, reassuring that most results are normal. And the ones that we do find abnormal have better outcomes if found early. Sometimes breast screening is not a priority or they don't have enough awareness about it. So that's where we come in. We're very happy to partner with the practices to support health promotion events or to share resources like Lena mentioned for your screens or for your practice websites. A lot of times when people say they don't have time or they're working, again, we do provide out of hours appointments and on the weekends, and they can do it nearer to their work as well, basically anywhere in London. And then the other thing that we encourage practices to do, if you have capacity, is, to, once you're getting that weekly outcome of women who have attended or not attended, to kind of get in touch with the women who've not attended and send them a reminder text. We are happy to provide a template of the text that you can send them to book their appointment. We are 2 health promotion leads across all of NEL. So on the slide, I've also put in the boroughs that kind of I oversee, and then there is Doris for the borough, the other 4 boroughs. But we'd be very happy to connect with you on ideas that you might have on how to improve uptake in your practice. And then there are some public health talks by Breast Cancer Now. These are really good. It goes over a lot of what I went over right now, but in all the different languages. So for your patch and for your practices, if there are certain population groups that you'd want to share this with, please access them. If we are caught in a community and our translators didn't turn up, we do end up using these sometimes. And there are lots of links to resources as well in there. So I'm going to stop there with 5 minutes for questions. But yes, very happy to take any questions.
Thank you, Mansi. That was really, really great, really informative. We do have a question in the chat. Nazia, I'm not sure if you want to come in or if you're happy for me to read. Okay, I can read it. It says, I'm a care coordinator from PCN in B&D. Could you send me the information on changing from post to PDF so I can forward it to the practices and ask if they would like to opt in?
Yeah, so we share these slides, and on the slide there is an email address. All you need to do is send your practice code, name, and the preferred email that you want that report to be sent to. You just need to send that across to the email address mentioned on the slide. So then you'll receive it in an email. It'll still be a PDF format. Unfortunately, I wish it was Excel and you could just send across all the DNA messages. We are advocating and working on improving that process and reducing the load for you. But at the moment, I think this is kind of our stopgap for the moment.
Okay, thank you. We have a search and a template for DNAs. They already have one in place. Okay, great. Are there any more questions? I mean, if you want to put your hand up or unmute and take the opportunity to ask any more questions. We've got 5 minutes left on the webinar, so this is a great opportunity for you to ask Lena or Mansi any questions regarding bowel or breast screening, as we're not going to have this opportunity unless you work with them directly, which obviously this is something they can help you with as well. So please take this opportunity if anybody has any more questions.
Hi, sorry, my name is Dr. Afzal. I'm from Eastern Avenue Medical Centre. I just wanted to please ask a question regarding the FOB test and the bowel screening. If we get patients who have not responded to it, what is what's the appropriate response to that? If we've sent, and they've been sent a notification to have the FOB test and they've not had it done, what should the practice be doing for that? Thanks for that question,
Humera. So, Humera, there are a number of things that practices can do depending on your capacity and resources. So in our patches, we've got a lot of practices where admin staff are calling the patients as well to remind them to do it. Some practices are sending reminder text messages as well. We're also working with practices to organise health and well-being days as well, where it's not just about bowel screening that I talk about. Other services are invited as well to get blood pressure checks. Some people are coming in to talk about mental health. We've got someone coming in to teach a bit of yoga. So it's a very holistic, I guess, event that's organized. But again, it's about time and resources. And I think the social prescribers, if you have got social prescribers, I believe not everybody has them, but they also play quite a key role in reminding people. Other options are sometimes practices, they set up a flag on the system. So if a doctor is seeing a patient who hasn't done their screening, there'll be a flag that comes up, and just the reminder about bowel screening coming from the GP, that's amazing as well. We've got an evidence based to that GP endorsement really works. So there are a number of things, even having videos in the waiting room areas, displaying leaflets and posters. So there are a number of things practices can do. I would say there's no kind of hard and fast solution. As I said, we do target our interventions, but Humera, what borough is your practice in? Because we've got other health improvement specialists as well.
Yeah, we're in Redbridge. I'm very sorry. I think I didn't frame my question properly.
Sure.
I was going to ask you, if somebody, for example, when I'm doing the result and I see got a couple of patients who have not responded to the fob.
Mm.
Is it appropriate for me to look in and see if they've not had a fit test in the last year, for example, to ask them to have a fit test, or do I direct them to go and seek getting the fob test themselves?
So if they're in the eligible cohort, Hamira, then they can be given the free phone number to request a kit themselves, for sure.
Okay. So I shouldn't be, I shouldn't be asking staff to kind of say, can we get a Q fit on this patient? We should just try and encourage them to call the fob.
Yeah, so I'm not sure I understand fob, Hamira,
Oh,
if
I'm
you
so
can,
sorry.
because ours is the fit test. So I just want to make sure I understand your question
I'm
properly.
sorry. Yeah, so in Redbridge we use the fob test
I
for the
see.
screening. So that's why I was going to say, if we don't have one, if someone's not responded to it, is it
Mm.
appropriate for them to then say, look, should we request a Q fit for that patient?
Right. So I think so that would you so is that the GP pathway for encouraging the fit test, I'm guessing, right? So
Yeah.
what we're finding is that if the person has symptoms, then it's better if they do the fit via the GP, because the sensitivity level's better. However, we wouldn't stop somebody from doing their bowel screening kit if they wish to do it, if they're in the age cohort for doing screening, and especially if they've missed it. But what we try and do is we don't tell patients that the bowel screening test kit is a replacement for the one that they get via the GP, because the GP one is more sensitive to picking anything up.
Okay, fine.
Is that all right, Hamira?
Yes, I
All
understand.
right.
Thank you.
Okay, thank you.
I think there's a question in the chat. Are there any false positives or negatives with screening tests for both bowel and breast? Or these are very sensitive and specific? Priscilla, do you want to expand on that question? Or so for false positives and negatives with screening for bowel and breast, or are they very sensitive and specific?
So sometimes we do get false positives and negatives with bowel screening, and we do say that no screening test is 100%. However, the fit test is I mean, it's a better test kit compared to the FOBT, which we used to use in the past, but there is no 100% guarantee. So yes, sometimes there can be false positives and negatives, but the numbers are quite low for bowel screening for those scenarios.
Claire, do you want to answer that one for breast, or should I?
Sorry, Mansi.
We were talking about false positives for breast screening. So I was just saying, did you want to answer, or should I?
So yes, we do get false positives in breast screening. Very often it is something called fat necrosis, which can often be disguised, or it can often look like a breast cancer when we recall ladies for assessment. Obviously, with the information leaflet, we are very open and honest with our populations with regard to that, so they are aware that that is something that can happen. We also have the other side of the coin where we do miss cancers. They're called interval cancers, and these are something we're monitored for, and we investigate and go back and look at to see, was there something evident there that we missed during the screening process, and if there was, what lessons need to be learned from this. So again, these are processes that are in place, there are audits in place, and there are reviews that are happening continually within the service. If we have a cancer that we've missed, so it's a barn door cancer and we've obviously missed it, then that gets recorded as a national incident. The patient is informed. We do a duty of candor with that individual as well. For those where it was occult or it wasn't seen previously, again, we do offer them that opportunity to come and see us for those discussions. And all our treating symptomatic hospitals are aware of these processes and how patients can access us to partake in these reviews. Does that answer the question?
Priscilla's microphone's not working, so if you have any more questions, yeah. Okay, great, thank you. One more question, just to clarify, is it FOB or FIT which is sent for bowel screening? In Leighton we see FOB for screening, so if you want to just provide clarity on that, Lena.
Yeah, it's FIT. It's the fecal immunochemical test that we use. So the previous one was called FOBT.
Yeah, I think there might be
I think there's confusion.
A system. It's on the system that it might still be FOB, but it is a fit test kit.
But the test is the same.
Yeah. Okay. I think if we're happy to wrap up. Thank you, Lena. Thank you, Mansi. Thank you, Claire, as well. That was a great session. If you have any other further questions, I have put Lena and Mansi's email in the chat. Please do get in touch. They're happy to do whatever they can offer in terms of health promotion. They're here to support you across North East London. Please do use them. They're a great resource. Thank you so much.
Thank you. Thanks, everybody.
Thanks,
Thank
everybody.
you.
Bye. Bye.
Bye-bye.
Thank you. Bye.